welcome to all of our students that are here. A big thank you to Dr. Dixon and Dr. Long John for arranging this, and an equally big thank you to Mo, and forgive me if I'm mispronouncing your name, Wilo, for organizing everything and getting everybody here. And the biggest thank you is for each of you to be here and to care about this issue and to make it part of your education, because it's critically important, in my opinion, at least. So my name is Lisa DelBuono. I'm a recently retired diagnostic pathologist. I practiced up in Traverse City, Michigan. I trained at University of Michigan. And I started an organization called Michigan Clinicians for Climate Action, and I volunteer for CCL. And we have a good group of docs here, and as well as a former educator from CMU, MaryAnn Renz. We all volunteer in the space of advocacy and health, either through CCL or through Michigan Clinicians for Climate Action. So we have MaryAnn Renz here, who's from CMU originally, Dr. Stephen Ashmead, who practices at Mercy St. Mary's Hospital and still teaches at MSU in family practice, Dr. Nan Barbas, who's emeritus professor at University of Michigan, and Dr. Mike Caplan, who's lecturing at Lake Erie Osteopathic Hospital and is a diagnostic and is an anatomic and clinical pathologist with expertise in forensic and pediatric pathology. If I didn't mention, Dr. Barbas has expertise in neurology and her master's in social work. So this is the crew that you're working with. And our objectives today are simple and not simple. We're going to, first of all, try to recognize how climate change may be impacting patients' health and acting as a threat multiplier, essentially taking a clinical disease that may be common and either making it worse or pushing it into a more critical situation. And that's part of what we want to look at when we look at our case histories. Two, we want to see if there are systemic inequities that are contributing to the clinical cases we're presenting. And then consider what your role is as a future physician in addressing these inequities. And consider whether there's a role for physicians to influence policymakers on some of these issues or advocate for climate solutions. So that's part of the discussion we're going to have throughout the day. And the way we're going to tackle this is, first, I'm going to give a quick overview on some of the health impacts of burning fossil fuels. It'll be very, very superficial and quick because I know that you guys know most of that. Then we're going to look at a relatively short TED Talk by Dr. Cheryl Holder that I think really nicely frames systemic inequities and the role of the physician. And then we were going to do one case history led by Dr. Caplan as a group. We're going to call it Jorge's story, and I omitted the S by accident there, sorry. And then what we're going to do is we're going to go into breakout rooms. And there'll be about 4 of us, I think, in each, 4 students, along with 1 or 2 of us in each of the breakout rooms. We'll take one of the case histories and we'll delve into it. Then we'll have a short break and hopefully be back around 10:05. We can adjust that time if we're moving slowly. And we'll come back. We hope one of you in each of the breakout rooms feels comfortable kind of presenting the history to the group, and we can navigate some important points from the case history and to educate the whole group about each of the cases. And then we'll have our take-home points and a discussion about some key questions that we've raised already at the end. So here's a quick little didactic lecture about the health impacts of burning fossil fuels. Typically, I divide them into immediate impacts and long-term impacts. So I can't advance right now. Whoop, there we go. Sorry about that. So if we start with immediate impacts, these are the impacts that happen from things like ozone and particulate matter, essentially air pollution. These are pollutants that are not warming the earth. And the good thing, if there is any good thing about these pollutants, is they fall out of the atmosphere very quickly. In contrast to greenhouse gases, which are warming the earth, but will hang around for decades after we put them into the atmosphere. So let's start with immediate impacts. And essentially these are things like ozone and fine particulate matter that comes from nitrous oxides, sulfoxides, which come from, driving our cars and heavy industry in cities and power plants, coupled with some natural occurring substances like they're called volatile organic compounds. They mix together along with sunlight, particularly in ozone, to produce these two pollutants, ozone and fine particulate matter. And really, in a simplistic way, it's a form of secondhand smoke. And it tends to disproportionately impact frontline communities. The term frontline, which you probably know better than me, is because these communities are where the heavy industry is, are where the heavy traffic is. And when we're looking at fine particulate air pollution in particular, the smaller the particles are, the more dangerous it is to the patient. Essentially, the smaller and smaller they are, the more likely you could have systemic impacts. So what are some of the systemic impacts that have been described with fine particulate matter? Well, it's been found to contribute to 1 out of 10 to 1 out of 20 premature deaths in the contiguous US. Worldwide, if you look at air pollution and fine particulate matter, it's a much higher level, maybe 1 out of 5 deaths. And there's a correlation, not necessarily a causation, between fine particulate exposure and cognitive difficulties in the elderly, increased incidence of preterm delivery, low birth weight, and stillbirths in the US. And the higher your exposure to fine particulate matter, the more likely you are to die from COVID. So a higher mortality rate related to fine particulate matter. So that's fine particulate. The other one I wanted to cover very briefly is ozone. And of course, you know that what we're talking about is we're talking about ground level ozone. We're not talking about stratospheric ozone. That's a good ozone that protects us from UV light, but the ground level ozone, that's a component of smog and a major trigger for childhood asthma in particular. And ozone is one of the air pollutants that's regularly measured when thinking about air quality. And one thing to remember when we're thinking about warming temperatures and the frequency of warming temperatures is that the warmer the temperature is, the higher your ozone level. Now, what happens when you have ozone? Well, it's an irritant to the airways. As you know, looking at your histology, you know that airways are surrounded by smooth muscle, and that irritant causes that smooth muscle to contract, decreases the lumen of the airway, so there's more resistance there. In addition, you produce a little more mucus, and you essentially have reactive airway disease. And we know there are many, many triggers that can lead to asthma, but two big ones include heavy traffic and industry and the pollutants related to that. So the level of asthma has been increasing in the US, particularly among populations of color and young people. And according to the latest State of the Air report from the American Lung Association, nearly 4 in 10 people live in counties where levels of air pollution are dangerously high. And it really is an issue of racial disparity. People of color are about 3 times more likely to live in one of those counties where the air is polluted, at least according to the American Lung State of the Air report. And then if you look at historically redline communities, that is communities that were broken up back in the 1930s and rated according to what was considered a more desirable level community, the green communities being more desirable, the red communities being redlined. And what you find is these historically, quote, less desirable communities, correlate with an increased incidence of asthma. So this is San Francisco, San Diego, and LA, but it's been done in many, many cities. If you look at the red line communities and the incidence of asthma, they tend to be very similar. So you can see that these early disparities are still being propagated into today, living today. Now, one last important point about air pollution versus greenhouse gas emissions is the fact that air quality improves quickly as you decrease your use of fossil fuels. And here's a real life example. Back in July of 2030, they closed a 10-mile stretch of the 405. You can see it's this big multi-line highway in California, and they closed it for about 36 hours. And air quality improved almost immediately for a radius of about 100 miles. And there was a correlative decrease in ER visits related to asthma. Similarly, when there was a part of the Atlanta closed because of the Summer Olympics, they found ER visits related to asthma decreased. So why do we care that air quality improves quickly? Well, the reason is that it's a good reason to transition away from fossil fuels, even if you don't take climate change into account. And as we transition to clean forms of energy, even not taking climate change into account, we will improve health, save lives, and hundreds of billions of healthcare dollars each year. So that's a message that resonates with the general population, even people who are skeptical of climate change. When we look at the long-term greenhouse gases, these are the heat-trapping gases like CO2 and methane and nitrous oxide. They warm the planet, and unfortunately, they take much longer these are natural occurring substances, and it's really about an equilibrium. So they'll be in the atmosphere for much, much longer. And according to the CDC, you can see that there are many, many health impacts. We'll just touch on a few. But I think the overriding theme is that, climate change can affect almost every aspect of human health. And many times it acts as a threat multiplier. And I'll give you one quick example. If we think about early onset pandemic, and you think about living in Midland, and right as it was starting, I think about May. So pandemic started in March of 2020, and then we're all in sequester, we're all in lockdown, we haven't got access to vaccines, and then the Midland floods occur, and all those people are forced quickly out of their homes, and there are no vaccines available. So it's an example of being a threat multiplier, taking something that was already there and making it worse because of an extreme weather event. And again, I'm sure you can't look at a single extreme weather event and say that one's definitely due to climate change. It's multifactorial, but the incidence of extreme weather events is increasing. So health consequences here in Michigan. Yes, Michigan is even affecting them. We've talked about air pollution, and air quality gets worse as temperatures rise, but it's also harder to grow healthy foods, and even our abundant water supply is at risk. We're finding more frequent and more intense algae blooms. That was the water in Toledo in 2014. They couldn't even bathe in it. The number of hot and extreme heat days are increasing, and the length of our warm seasons is greater. So the length of time of our allergy seasons and the length of exposure to ticks and to mosquitoes, which can carry viruses or bacteria, has increased. And all of these things, either climate anxiety or being forced to move abruptly, climate migration, is leading to mental health impacts. So that was your whirlwind overview. Everybody doing okay? Are we ready to quickly go to a TED Talk?
Good morning, everybody. So I'm going to share with you the story of Jorge. So basically, it was a warm and humid day in the summer. It was about 90 degrees Fahrenheit, about 80% humidity. So the temperature index was 113. Jorge is a Spanish-speaking seasonal farm worker who works in Bangor, Maine. has type 2 diabetes. As a measure of his, glycemic control, his last hemoglobin A1C was 7.5%, the reference range being less than 5.7%. He also had borderline renal insufficiency. So he had a GFR, glomerular filtration rate, of 55 milliliters per minute. So that would put him in the GFR category of G3A, normal being 120. So that's his background medical history. He presented to your Intercare Community Health Clinic with intense thirst, weakness, nausea, fatigue, and headache. He was brought in by his wife, who says that when he got home earlier, he seemed to be confused, and he was repeating tasks for no apparent reason, like he was putting, the mail in the same place and moving it for no apparent reason. She got concerned. She took him to the clinic. He was noted to be a little bit tachycardic. He had a pulse of 110, and he had a core rectal temperature that was a little bit elevated, just above 100 degrees Fahrenheit, 100.3. His skin was still moist. Okay. His wife tells you that he becomes more ill after long days of work. If he takes a few days off, he does better. But as he says, and as Dr. Holder said in her talk, rain or shine, cold or heat, Jorge has to work.
So that's a history. And what do you think? How do we dissect this?
So we need to know, some of the questions that are going to come up are going to be, first of all, what's actually going on with this patient. We want to know whether did climate, does climate change have any role or impact in this case? Can we identify any systemic, failure that may have had a contributory role in his illness? And is there any role as us as physicians to discuss climate change with the patient? Those are some of the main questions, that came up, and those are also some of the questions that are going to come up for the breakout cases. So basically here we've got a story of a man with underlying type 2 diabetes and borderline renal insufficiency. So those are his underlying comorbidities. And now he's exposed to a heat stress. Okay. And so what he has is probably most consistent with what we call heat exhaustion. Okay. It's not heat stroke yet, but he's got some signs of heat stress. He's got slightly elevated rectal temperature. He's tachycardic. His skin is still moist. If it was completely dry, then we would be worried more about, actual heat stroke. So it looks like he's got signs of heat exhaustion. And again, where Dr. DelBuono talked about, the threat multipliers. Well, again, here we have a situation where we've got underlying disease that's exacerbated by external factors like the climate conditions. So when he's exposed to, a high temperature index like 113, his ability to compensate, becomes challenged there.
Nice.
So I think that we can say that climate change impacts the case in the sense that he is more susceptible to those periods of heat stress. And in terms of an underlying systemic failure, that may have contributed, it's, what it really has to do with what kind of resources does Jorge have that may allow him to better address those heat issues so that he doesn't have to, get to the point of heat exhaustion and presenting to the clinic.
Should we
There's some other things that he can do.
Should we stop and see if some of the students have some ideas about other systemic failures or roles of the physician? Would that be okay, Mike?
Absolutely. Yeah.
So what do you guys think? Are there some underlying systemic failures that may have contributed to the patient's illness? Or is there a role for us as physicians to talk with him about how climate change might be affecting things? Any brave souls?
Lisa, if no one volunteers, you are welcome to just call on people.
Oh, that's new to me.
I can try to chime in a little bit.
Sure.
This is Sabwa. Yes, we could educate him on how the heat is affecting his health and how maybe on the days that he predicts or the weatherman predicts the heat is going to be high, he could maybe try to stay home. But again, like the family said, he has to work. But maybe we should address that part. Why does he have to work? Is there a system or resource that we can send him to where he may get some employment benefits or unemployment benefits on the days that this is a health risk for him to go out there? So maybe attack it from that point of view.
I love that. That's a great idea. And again, I think that's where, at least when I was in medical school, I don't think we ever thought about these social supports and learned about them to the extent that we probably should have. And yet, I think if you did know what was available in your community to help support somebody in such a situation, that could be really helpful to the patient. What do you think, Mike?
Absolutely. Yep. I think that's great questions. Yeah, why does he have to work, and trying to identify those things that that we can make some interventions on.
Great. So other thoughts before we move into the next phase of what we're going to be doing for our present, for the next part of the class. Any other thoughts on Jorge? Yes, please, MaryAnn.
I'm wondering if there were a way for him to be hydrated while he's outdoors at the farm.
Yeah. That's a great idea. Either encouraging him to, bring with him something that would allow him to be hydrated. Again, there might be some financial restrictions to that, but if we could find a way that, there are thermoses and water bottles and stuff that they could carry some stuff with, or encouraging the farmer, the place where he works, to provide better hydration. Other thoughts about how to do what MaryAnn suggested?
Well, I would just like to add to what MaryAnn said is that, and this is a personal thing, I think we underestimate how quickly we can become dehydrated. Even in non-climate, even in non-acute conditions. So, I think that just an awareness of being, hydrated, just across the board could be something that could be helpful, as more a preventative thing. And again, MaryAnn and Lisa, you'll know better than I do, but there's a certain number of ounces or glasses of water that are recommended, per day.
Yep. And again, I do this and I show my little insulated water bottle, which, is 30 or 40 bucks, which may be prohibitive for the average person and doesn't actually hold that much water. Not if you're outside sweating and working really, really hard. I know because I've tried to carry these with me and it's not a good choice. MaryAnn?
I'm wondering whether there might be some legislation that would require people who are hiring migrant farm workers to have breaks, to have liquid available for them, to have shaded areas for rest breaks and so on.
Yeah. And so, okay, let's say we're in a clinic and these questions come to us. There's a good chance we're going to be leveraged enough that for us to do that research might be really difficult. Not impossible, but it might be more than you have an energy for on a specific time. But I noticed that Dr. Holder then referred some of her patients to the social worker, right? And maybe that person would have the bandwidth or know of people in the system who could actually research those things and get back to you. And it would be a matter of following up on that so that there would be the potential to use our voices in that way to encourage such legislation or policy making. Is that what you're thinking, MaryAnn?
That's a great idea.
And
I didn't know that I was thinking it, but I think that's a great idea.
I just wanted the students to be aware that the clinic that Dr. Caplan referenced for Jorge is in Bangor, Michigan, and it is actually a migrant healthcare clinic. So, which I haven't worked there, but I've worked in other migrant healthcare clinics, and they have an understanding of what the federal laws are and what the expectations are for the farm workers. And they would have the social workers there because it is a federally qualified health center as well that would
That's
be
good
able
to
to
know.
provide the resources. And so
Yeah.
encourage students, if they get a chance to work in areas like that, they'll learn a lot that isn't
Nice.
necessarily right in
That's a great point.
Kalamazoo. So,
And I
Yeah.
think we linked to that site, so you can read about it. Mike?
Yeah, no, thank you, Steve, for pointing that out. That's an excellent point.
Okay, so what we're gonna do now, because we're at 9:40 and trying to pay attention to time, is I'm gonna, so silly, I'm gonna do my little PowerPoint, even though it's probably really not necessary. I wanted to show you I wanna go here real quickly, because what we're gonna do is we're gonna take about 20 minutes and break rooms, and there'll be some of us in each of the breakout rooms, and we're going to take one history at a time. And I put the questions on the right in the chat so you have a chance to see them, but these are the questions we want to ask for and I also put the histories, a Google Doc with the histories in the chat. So you might,
Lisa, you need to ask the students if they're able to access those Google Docs, because I'm having a little problem. And it might just be me, but I want to make sure nothing changed, that the students, yeah, exactly. I don't have access. I can't get access. So I suspect it's a new document.
Thanks a lot, Steve. I tried to do it. Emily, can you take care of that, please?
Another thing is I added those Google Docs to the Google Drive, and I just email the students a link to that. So if they can't access it, they can access it through the Drive.
Perfect. Thank you so much. Don't you love technology? Great. So hopefully everybody's going to have access to them, because you're going to need that in the breakout room. And these are the questions that we're going to ask. Thanks, Steve, and thanks, Mo, I think that was, or whoever that was. Thank you. So here are our questions. What is going on with the patient clinically? And of course, now we're stuck again. Okay, how did climate change impact the case that we're discussing? Can you identify an underlying systemic failure that contributed to the patient's illness? Is there a role for the physician to discuss climate change with his or her patient? And do you have a personal or clinical story that demonstrates the role of climate change with or without a component of systemic inequities? So those are the questions that we're going to discuss. And I think we're running a little bit behind. It's 9:44. So let's say that class resumes. If we did 20 minutes, we would be at 10:05. So let's say class resumes at 10:10. That should allow you to have 20 minutes and also a little bit of a 5-minute break. And I can't get 10:10 in there. Everybody remember 10:10, okay? So